So thank you so much. It's a great honor being here. Yes, I'm from the UK, always expecting rain. Really nice to see wonderful weather. And even nicer because one of the things is we have been using lately large language models created in this supercomputer center that is behind us. So I'm super thrilled just to be nearby. So one question is, why junior doctors? So in the UK, junior doctors is half of the clinical workforce. So half the clinicians that may attend you, if you go to a hospital, for example, chances are it could be a junior doctor. Sorry. Another thing is Judgment Day. We call it Judgment Day because we wanted to help clinicians, but really wanted to help them, it doesn't necessarily translate into doing something useful for them. So we call it Judgment Day, like we wanted to help you. We really wanted to help you. But is this useful at all, what we do for you? And the call was, can we pass Judgment Day? Can we do something that they will say, actually, I may use this once again, yeah? That was our goal. One question for you all. How many of you work with clinicians or biologists, or perhaps you do things as part of a team? How many of you? So perhaps Judgment Day, it can make or it doesn't make sense for you. So my apologies if this is not exactly your call. It's definitely my call. So 2 quotes that will be incorporated in the latest version. It is recognized that healthcare depends on unstructured data. Doctor notes, X-rays, CT scans, and what you're going to hear today is about research articles. This is from IBM, take it or leave it. Another quote, this is 2019, probably things change a little bit. This is this Global Innovation Index. And they say that 97% of healthcare data goes unanalyzed or unused. So the motivation seems to be there. So what is the challenge? So we have the biomedical literature, and we have clinical documents like electronic health records, and even patients or doctors are very active on social media. But this seems to be like completely different silos. And it is widely acknowledged this existing gap between what we know, what is health research, and what clinicians are doing, which is the health practice. And there is a lot of concern in order that the clinicians deliver the best care based on the evidence, on the scientific evidence, on the latest information we may have. But this is the reality. So in the UK, they will have 314 NICE guidelines. You will have 1,000 BMJ best practice documents. And in PubMed, if you go there are 37 million papers, but daily, Monday to Sunday, no stop, more than 2,000. So it's not only the information, it's also the continuously being growing and updating. If you wanted a global picture, perhaps this is like different steps, or you can see what is PubMed, where are the clinical guidelines, where is the clinician support and the clinical care, and how all of this is reported somehow and fit into the loop. And this is, of course, what is known as the quality improvement ecosystem. So in healthcare, there is a lot of concern in doing better, in deliver better care, in doing better for the people. However, we know that evidence is important, and ideally everybody would like to be treated according to the latest scientific evidence and to have access to the latest treatments or the latest tests. But if you go to the high quality, which in this case is the top of the pyramid, which is systematic reviews, you have nowadays more than 300,000. So it looks like it's unmanageable. Clinicians, even if they wanted to deliver the best care, they have problems with that. So face that if junior doctors that are still on training, is half of the clinical force, and they are already acknowledge their gaps, of course, they are willing to have help. But the problem is, can technology help them? Can we actually do something for them? So, people like me, I'm not only from the previous century, I'm from the previous millennia. And in there, when I was young, we hear this idea about computers being useful. And I'm from physics. So imagine, instead of working with numbers, you work with knowledge. But the really, really exciting times is nowadays when everything, like these differential equations and super large matrix that I was working as a youngest, it makes a lot of sense when you work with large language models. So the old dream, perhaps is still there, that the computers become useful and they seem to be, I don't know, an interesting companion. So in this study, what we were doing, so we know that there is a lot of unstructured data that perhaps is worthy to do something about it. And then, as many of you we love and we believe in knowledge graphs, they are good. But how we go from the unstructured data into the structured data? So we try two approaches, and there is a third one, more automated, of course. But we will try to do this automatization with some quality assurance. Another interesting picture is how we put these efforts about processing knowledge that the machine can understand with the healthcare world. So in the healthcare world, change is vital. So they have this cycle, plan, do, study, and act. And we already tried to link whatever we were doing with this, thinking that if we were lucky, we even know how to embed a technical solution into their workflow, into something that they already know. So in the UK, this plan, do, study, and act is something that hospitals even do for a very small changes with this aim of quality improvement. So perhaps technology can be thought in here as another quality improvement that perhaps can go also or be incorporated into this kind of cycles. We were very optimistic at the time, of course, if we pass Judgment Day. So I give you Symbolic AI, I give you CommonKADS. It's a very solid methodology. Perhaps most of you know or don't know. The whole book is even available for free. I just give you the different stages that for some of you can reckon: the knowledge identification, the knowledge specification, and the knowledge refinement. And of course, later on there comes, things like ontology 101 and other methodologies in order to create ontologies, not only in a more efficient way. However, we stick to this one, which is the classic, as opposed to something with a bit of more flavor of the latest trends. So we also consider 3 steps, like extract, represent, and present. And the really, really important thing is when you present, when you actually have your final product, your mobile application or your web application, is this something that a junior doctor can use, for example, and find the kind of answers that they are looking for? So we were lucky and we established a project, a proof of concept with BMJ. BMJ is the British Medical Journal, and all the content is available for free to clinicians there. Unfortunately, not to everybody, which seems to be now a problem in order to share openly everything we did. And we also were lucky because we have an NHS trust, a hospital. And perhaps it's not the more flavor one, perhaps it's not one of the top 10 hospitals in the UK, but we wanted that particular one because we know that if we can make it on that one, perhaps others also look or consider what we were doing. If you wanted a bit of more details about what is this SENDIP, semantic deep learning, is we use the old tech. The old tech will be static embeddings with the skipgram and cbow. We apply arithmetic formulas completely unsupervised. From there, we can get, applying these formulas, we can get term pairs like asthma and formoterol. One is the disease, one is the treatment. Map it to concepts, and then, of course, having RDF in order to create nanopublications and micropublications, like what is the provenance, how you extracted this information, how you say that formoterol could be a potential or an effective treatment for asthma. What kind of evidence do you have? A quick review, if I'm allowed, which is when you work with embeddings, what is the notion? So vectors representing words. What makes them interesting is as soon as you have numbers, vectors, you can do vector operations. Like jaguar could be a car, but could be an animal. So you may have the idea, okay, if I have a vector that can represent the car and the animal, if somehow I subtract the part of the vector that represents the car, then what I will have left is just the animal. And the jaguar seems to be pretty similar to tiger. So what blew us our mind at the time is, imagine that, just do mathematical operations with words. And probably it makes sense somehow, because with this technology, if two words are similar, then their vectors are similar. So with these static embeddings, and with the super famous Mikolov, Seebow, and Skipgram, just using cosine for something like heart failure, and using embeddings from the literature, from these more than 300,000 PubMed publications, you know, the systematic reviews, the top of the pyramid in terms of scientific evidence, this is the kind of, let's say, top results that we were obtaining just with the cosine. Immediately, we were thinking, oh, maybe we can do more sophisticated and we can do analogies. Unfortunately, at the time, everything was super dominated by pairwise analogies, like king and queen and men and women. And we were thinking, but this is just a type of analogy. Perhaps we can work something else. And we did. And if you look about it, now there is something on the literature about using four-term analogy instead of pairwise. So what is the knowledge? The knowledge is to use this formula, we use background knowledge, like what is a disease and what is a treatment. And what we wanted is perhaps if we feed the formula with the name of a disease and also treatments, we wanted more treatments. So you can see here that, again, Seebow and Skipgram, but now you can see the top list of the results. These are treatments, as opposed as here. In here, with the cosine, you don't have only treatments, but in here you have. And it's just a question, we didn't modify the embeddings, we just modified the formula and how we use it. So keeping that in mind, two alternatives, the classic, more manual, and then these other more unsupervised formulas. What we did, yes, we created nanopublications and we also created micropublications in a proper way. And we have quite a number. Another thing that some of the people were asking is, did you take into account that, for example, these documents change over time? Yes, we did, particularly with COVID. And we managed to just update one of these documents and create the nanopublications and micropublications, even if the process was quite manual, in less than a week. Because what happens? Not everything changed, just certain things. But the question is, okay, so you have two alternatives from the point of view of the technology. You know how to represent them, and now what? So this could be an example of the mobile application, where you just have a text box, and the clinicians started to type, and then you will have a list of things, and they selected whatever they want. What we wanted is to see if these knowledge graphs, in a very simplistic web interface, it can be useful somehow for the clinicians. And again, junior doctors, they are also the next generations of medics. So whoever is a junior doctor today could be a medical doctor tomorrow. And if the experience with technology is positive, you will have a great alliance. So we were working not 5 years or 10 years down the line. We try to do something more longer term. This will be the web-based applications, which perhaps, again, you can see that in the mobile phone, there is not so much variety. There was quite some variety in terms of the more sophisticated web interfaces that we did. The SEMDIP is specifically about treatments and medications. What for the COVID-19, this was a bit wider. You can see, as I was trying to tell you, that for the mobile phones, it looked like exactly the same, but of course, the content is different. So what the clinicians were saying, we asked 2 senior consultants to propose questions that were pertinent for the junior level, and we give them the questions and we give them access to these applications, and this is how the study was set up. We use the SUS because it's a standard tool for measuring usability, and these are the 10 typical questions, and for each question, it was this 5 scale from a strongly agree to a strongly disagree. This is the best imaginable system that, as you can see, is a perfect start with use frequently, easy to use, well integrated, learn quickly, and confident to use as the peak of the star. So what happened with the demos? Well, if this is perfect, they are definitely not perfect, but you still can see the star, and you still can see that they will say use frequently and easy to use and well integrated and learn quickly and confident to use, more or less. So it seems that it could be useful. Another way to represent is for each of the participants, which were 13, you can plot the individual score and then the mean. And what we noticed, it was surprising a little bit. The COVID demo, which is more classic, it looked like the results are more or less close to the mean SUS score. But for the semantic deep learning, there were people who love it and will give it, the maximum score, the perfect score. And there were people who, I don't like it at all. So it was, completely on the other side of the spectrum. This with them completely unaware of the technology that we were using, which was part of for us, our inquiry. We're going to use something classic and something a bit more novel, but we're not going to tell them which one is which. However, you can see that the score in net is not so different, 80.38 and 73.46, which means that, yes, it could be potentially useful. Some of you or some of the reviewers have intriguing questions, like, did they answer all the questions? So 9 of 13 for COVID, yes, they say that they answer all the questions. For semantic deep learning, 10 out of 13 say that they answer all the questions. However, when we ask out of curiosity to the ones that says, I couldn't answer all the questions, they were saying, oh no, it's because I really don't like the answer. Okay, so perhaps we need to go more into the depthness, like there is evidence, but perhaps for them it's not sufficient, the evidence that is there. So it looks like there are 2 completely problems. It's not only enough to try to get them the best evidence available. For them, even the best evidence available perhaps is not the best one. So I leave you with just these thoughts and the message that, yes, knowledge graphs and power or trying to do the extraction in a more automatic way could be potentially useful for clinicians, so perhaps it's worthy to look into. And the more important message is, after this study, as you can bet, we started to look seriously into large language models. Some of them, apparently, are created around the corner, which is really exciting. So thank you very much for being here, and I'm open to questions.
having helped the junior doctors, do you think there's a chance that you can help the senior doctors?
Well, as junior doctors are half of the workforce, tell me where I have to sign on to get just half, because I think it's most worthy. I'm just saying because sometimes we are obsessed with helping consultants, but what about helping half of the doctors in one go? Is this worthy? In the UK, at least, it looked like it could be really, really, really